So I would like to start by introducing Kotie Bester. So she's a pediatric anaesthetist. And we have the saying of never fear when Kotie is near, because she will always bail you out, and mostly with your vascular access. So Kotie, we are so happy to have you today, and we know that we're going to learn from you so much. So we can't wait for your presentation. And I would really encourage you guys, so this is the last presenter, so please post your questions in the chat, and we can have our presenters answer that for us. Thank you so much.
Ultrasound rescued me when vascular access felt impossible. I was studying for my part 1 college exams, and we had to learn about the physics of ultrasound. This may have been at the turn of the century. Didn't understand why I had to study it, because I'm studying to become an anesthesiologist, and ultrasound is for obstetrics. But subsequently, things have changed, and ultrasound has definitely made inroads into anesthesia, and it's definitely it's won hours in my life where I would have been struggling to find access in babies. Obviously, it decreases complications, it increases accuracy, and in first world countries, it's often mandatory to use it when you're doing central line insertions, and so it's absolutely now become an irreplaceable tool in my armamentarium. So let's then just remember a few things about the physics of ultrasound. That it is a high frequency beam that is used, a bit different to normal sound in that it doesn't go around corners, it travels in a very straight line, and where there's impedance between tissues, some reflection takes place. And therefore, the higher the frequency of the beam, the better the resolution that you will get, because small particles can cause the beam to bounce back. The probe then senses these signals of the beams that bounce back and make a picture out of that. Because the light travels straight, you will find that you only see whatever's in that beam. You can think of it as like a paper thin or even thinner slice through the tissue that you are looking at. And if you see a little dot, that could be the shaft of the needle, it could be the tip of the needle. You don't know exactly what part of the needle it is. You only know that that little dot is likely to be the needle. Just other relevant issues about the physics is that ultrasound doesn't really go through gas, which means that when you prepare ultrasound, so often when I do just peripheral access, I'll put a clear dressing over the probe to make it keep it clean, so like a tegaderm. But when we do central venous access and A-lines, we often use a sleeve, a plastic sleeve, and then you want to put some ultrasound jelly inside the sleeve so that there's absolutely no gas in the interface between the probe and the patient, and make sure that there are no bubbles in that, because that will just ruin the day for you. The other thing is that it is absorbed by bones. In this picture here, you'll see rib, pleura, rib, and beyond that rib, you can't see anything because the bone has absorbed all the beam and nothing bounces back from further beyond the beam. And that just becomes relevant because you have to plan, like when you do a subclavian vascular access, you will have to think of the clavicle that's going to be in your way, and you can't look through the clavicle. So you would want the highest frequency possible to get the nice, clearest, highest resolution picture. But the higher the frequency, the shorter the distance that the light will travel, and therefore there is a trade-off. So you're gonna, when you in children, often you need a centimeter or 2 depth So you can get a nice high frequency, high resolution picture. But as you go for deeper vessels or in adults, you will need to increase your distance, and that will be at the cost of frequency and therefore resolution. Gain setting is always going to be important, and for some reason in our ultrasound machine, that is this default gain. So it starts with a very dark picture, and then you need to increase the gain. That's overdoing it. Everything's very white, and you want something where you have a good discrepancy between the different tissues, and you can see them nicely. Gain doesn't do anything about contrast. It's just everything is whiter or everything is blacker on the picture. When ultrasounding vessels, you want to be able to discriminate between arteries and veins. And as you can see nicely in these pictures, arteries are always nice and round with a thick wall. Even on the ultrasound, you can often see the thick wall, it almost looks like a double shadow. Veins with thinner walled and are not always as round. So especially like the internal jugular vein will have this kind of shape. The other thing about veins that could identify them is that they may have valves in them. So if you do see a valve, then you will know this is definitely a vein, not an artery, and that they are easily compressible. So the veins will have the thick walls. They may be a bit irregular. They're usually compressible, as you can see in this picture of the internal jugular vein here, carotid artery. You see that double shadow that I talked about, the thick wall, the thin wall, irregular shape, and easily compressible. The arteries are supposed to pulsate, hopefully if all things are going according to plan, but veins can also pulsate, especially if you have something like a tricuspid regurg or something. So don't be fooled if you see a pulsation. When you start off with ultrasound, I feel like there's a sort of a pyramid of learning, and one can start off initially by just using an ultrasound on a patient to identify the vessels. So you have a patient, before you even prep them for the line insertion, look at the from outside, see where the vessels are, mark it on the skin, and then you do your prep and your drape and leave the ultrasound to the side and insert your line. I think one should advance from this rather rapidly to a more real-time technique. So that would be the next one, where you use an outer plane technique. So you will have your ultrasound, if you're going for the internal jugular vein, you'll have your ultrasound probe over the vessel, and then as you advance your needle, hopefully your needle will come into position and you will see it. So this is the type of thing that you'll have. Probe placed over the needle while you are needling in the vessel. The problem with this is, as we said before, we're only seeing that paper thin slice through the tissues here. So if you are lucky, you will catch the shaft of the needle as it goes into the vessel. But it could be that you see your needle here, and then you just keep advancing and it's blind because you don't know where the tip is going. So this is a good place to start, and one can do this for quite a bit. But if you can advance from here, you can make your placement of your needle even more accurate. And that is by dynamically following your needle tip. So what I mean by this is that you will insert your needle. As soon as you see a dot that represents your needle, and that will often be up, hopefully be before the vessel even, then you slide your ultrasound probe. So if you've got a needle there, your ultrasound probe is here, you now see a dot, and then you slide your ultrasound probe until the tip of the needle disappears, as in this picture. Then you know you've just seen the tip of the needle. This was definitely not the shaft. Now you keep your ultrasound probe in that position and you advance your needle again until it gets into view, which means that you are now dynamically following that tip of the needle. And by keeping that going, that whole process, sweep the beam, push the needle, sweep the beam, push the needle, you are actually following the tip of the needle and you know exactly where it is. So in this way, often you can start before you hit the vessel. When you do get to the vessel and you start seeing your needle in the vessel, sometimes you won't even get blood back. And especially in children who have very compliant tissues, sometimes I think there's still intima, and you're not actually in the blood, even though looks like you're in the vessel. So this is a very good place to then try, I call it ride in the vessel. So you keep doing this dynamic following your tip, but you try to stay in the vessel. You try not to go through it. You'll see if you do this, for instance, on a femoral vein, often you'll end up having to, if you advance towards the vein, you have to flatten your needle out so that you can stay in the vessel. And if you look down onto the thigh, because remember, when you do ultrasound techniques, you don't look at the patient, you're looking at your screen all the time. But if you do look down at the thigh, you will notice how the hub of the needle is denting into the thigh of the baby as you're trying to stay in the vessel. I'll show you a little bit more about that later. And then the tip of the iceberg is using an implant technique. Now, this needs a bit of dexterity, and I find that it's not particularly easy. So that's why I think that's the last technique you want to learn to do in ultrasound. But basically the meaning is that now you identify the vessel with your ultrasound probe, and then you put the needle in line so that you can see the whole needle as it advances. You'll see it coming in from here, and you'll advance and put it into the vessel, all under view. It is difficult because there are three things you need to try and line up all the time. So your ultrasound probe, the vessel, which is stationary, and then your needle. And to get those three things to line up can be quite difficult. The other important thing is that you must ensure that you see the whole needle. So if there is a slight oblique alignment between your needle and your ultrasound beam, then it may be that you see a bit of needle. It won't just be a dot, there will be like a little line, but it may not be the tip of the needle. So always make sure that you see the whole needle, and especially in this kind of condition where you see there your needle is, and this is the pleura. So we'll discuss this technique a little bit. Okay, so that is your ultrasound. You take from easy to difficult. Now, in terms of vessels, I would, if I can, start with big vessels and work my way down to smaller vessels. Now, again, for me as an anesthesiologist, it's easy. Most of our patients are fully anesthetized. I can intubate and ventilate them and keep them still, and we often need to do central lines. So that's where we would start. Of the central vessels, the internal jugular vein is the biggest in children. So that's, again, a very good place to start. And if we just look at the anatomy of the internal jugular vein here, you can see that on the right-hand side, it's a nice straight line down to the brachiocephalic, down to the SVC towards the heart. So that's why the right side is the preferred side for internal jugular vein access. The other thing is, they say that often the right side is a bit bigger than the left side anyway. You can see why we often have trouble if we do have to use the left side. You've got these angles, 2 angles that you have to take to get to the heart, and often your guide wires will get stuck and things just won't go the way they would need to. On this picture, again, you can see nicely the valves that we mentioned before. So if you see a valve there just before the internal jugular vein joins the subclavian vein, each of them have a valve. So if you see those valves, again, a reassuring sign that you are actually looking at a vessel. Again, just look at this picture. Look at that beautiful round artery, thick wall, the carotid artery. So then I think the next favorite would probably be the femoral vein, simply because it's so accessible in quite a sick shock type of patient. You probably don't even need a lot of sedation, a bit of local anesthetic even, and it's easy to access while CPR is ongoing, etc. The one thing I want to show you, and this has taught me a lot when I realized this, is we often, isn't that the most frustrating thing when you can get blood back and you just can't feed a guide wire. And on this picture, you can see why. So this is the artery, but the vein does exactly the same. You see how it curves over the pelvic brim. So you can imagine if your needle came from this side and you hit it and you get blood back, and you try and feed your guide wire will just bump into the back of the vessel wall there. So again, this is a nice place. Often when I struggle, I'll use the inline approach, because then I can get in, flatten out my needle and try and follow a little bit in the vessel, just increasing my likelihood of the guide wire to actually feed. Then, of course, the third big vessel that we are used to cannulating is the subclavian vein. Now, the subclavian vein, as we mentioned before, has the issue that the clavicle is there. So that takes away some of your ultrasound options. One can, I have in the past, scanned the vessel from the top and then use sort of my anatomical approach, and then you just see your needle come into line when you get close to the vein and you hit the vein. But what I do nowadays is I actually take this part of the vessel, which is easily accessible on ultrasound because it's still distal to the clavicle. It's still called the axillary vein there because it only changes its name as it passes under the clavicle. So go for the axillary vein, identify the vessels usually by putting my probe in a transverse position, then turn the probe so that I'm longitudinal and aim for the vein. Yeah, you will have to ensure that once you've turned your probe, again, you're looking at the vein, not the artery. And it can become quite deep. So it's technically, I find the subclavian vessel to be probably the most difficult of these three. If you do struggle, so that's how I would
and you make the
over the sleep. Which, and for me, some of my colleagues love it and would use it as a first line, but I feel it's much more likely to have complications. Which is something I use especially on small babies and particularly difficult patients. So here you're going for the brachiocephalic vein there. So after the internal jugular and the subclavian have joined each other and they make the brachiocephalic. Again, now you'll see the left-hand side, similar to the body of the clavicle is right here, so the probe is just above the clavicle. Usually I start off by scanning the internal jugular vein up in the neck here, following it down until I get to the rib. And then as you get to the rib, now you won't be able to see anything anymore. So you stay just above the rib and then you start tilting your probe down, down, down so that you're looking into the chest. And until that internal jugular vein and the subclavian vein open up and they show you this nice brachiocephalic vein. And you do an inline approach. Now, as mentioned before, the pleura is sitting right here. It's an area with big vessels, nowhere to compress there, so you have to be absolutely sure that you're looking at your needle in full view so that you don't get unnecessary complications. I always say that many times. I always say that I was so ashamed that I once had to do just an adenoidectomy. That's a 10-minute procedure, very simple procedure, with a central line because I couldn't get a drip up. Well, now maybe I'll try a few other scan any biggish peripheral vein and access that with ultrasound. So you can imagine in the cervical area, that's probably a good place to start. We have definitely used some of these cephalic veins before. I've gone in the forearm. Nowadays, I know, I think other people are just so much better than I am. They go for saphenous veins blindly and they just get them in. My success rate's not that good. So when I start thinking of a saphenous, I actually call for the ultrasound, and I prefer to go for the saphenous with the ultrasound from the start, because as soon as you hit it and you didn't feed your cannula, that ultrasound is messed up. If that happens, what you can do is just carry on scanning up the leg and try and find the saphenous again. And we managed to do that in these 2 patients in the last month. This is a slightly older girl, about 2 years old, has spent at least the last 6 months in hospital. So all her veins are gone. And this baby also, I think he's now left hospital, but spent his first 4.5 months of life. This was just before it was his last procedure before he could go home. We had tried the saphenous. I think I personally did that and pranged it there, and it was gone, but managed to find it again halfway up the leg. And then if you get these kinds of veins, and they, especially if they are for instance, we have patients coming for radiotherapy who come daily for up to 7 weeks with sedations. And then we may place some of these midline catheters. And of course, mine last 2 days, but my colleagues have had 2-3 weeks of use from these midline catheters. So that becomes a very useful thing to have. So in summary, you want the optimal equipment for what you want to do. So in vascular access, we prefer to use linear probes because your beams, your resolution remains the same as it goes down. If you use a curvy linear probe, your resolution at the bottom decreases. And then ergonomics. So the ultrasound machine on the screen in front of you with a patient between you and the machine so that you don't have to look there while you are doing your procedure here. And then try to right hand with the ultrasound. And what sometimes helps is if you can take the hand that's holding the ultrasound probe and rest it on the patient, it just helps you keep a light hand so that you don't accidentally press the vessels. That's the last thing you want. And then with, in terms of the things that you're going to do with ultrasound, you're starting out, start with basic techniques and work your way up, increase your experience, increase your dexterity, and then until you get to the more difficult ways, and try and find big vessels first and go for them first, and then work your way to the smaller vessels if it's possible for you.
Great. Thank you so much, Kotie. I don't know if there's any questions at this point. Anyone that's got any questions? Okay, so we've got that baby that has been unmuting herself. So most people are just saying nice presentation, and most of the time there's no backflow when using the ultrasound for CVPs. And we do not know for sure if we have passed the vein due to the view. How can we confirm position of cannula in the vein? So I don't know if you want to answer that. But you just need to unmute yourself.
So the first thing that I agree, often as you go in, you don't see backflow. We tend to use IV cannulas to go in with. So we don't generally use the needles that come with the sets. What I would do is I would go in until I think I'm well into the vessel. If I can, use that technique that I described, where you ride in the vessel and make sure you're deeply into the vessel. And then I will take my needle out and just leave the cannula, and then you usually get backflow.
Yeah, so I think that is good advice. So I'm just going to take off my mask. One thing that you guys have taught me that also helps, especially in your very shocked patients sometimes, and you don't know if you are actually in, is actually to give quite a big flush of 5 mils of saline or fluid. And that sometimes just, if it's a very collapsed vein, just helps you to actually open it up. And then you can sometimes get your wire in. But again, it is very useful to use actual gel coat to go in with, and your gel coat, as soon as there's a bit of flow back, or as soon as you can flush it easily, that just helps you to then use your short wire and then perhaps a longer gel coat. So I don't know, that's something that I've learned from the anaesthetists.
Something with the babies with the small vessels, even when your whole line is in, your central line is in, every now and again you won't get them to aspirate, but they will always flow back with gravity. So if you just have something that lies open, like even your CVP, if you just open it to air, downwards, of course, so that it doesn't entrain air, then blood will slowly come flushing back. So the same thing happens with your IV cannula.
Any other questions from anyone? Okay. Thank you so much, Kotie. That was really great. And thank you for everyone that stayed so late. This was really great. Oh, there's another question coming through. So I think we do have another 2 minutes to answer that. So what size IV cannula would you recommend?
I assume that is when I use it to access poor central line. In that case, I actually go for a bigger one. So I use like a 22 gauge. I don't suckle with a 24 gauge because you're going to end up putting a big guide wire and a big central line in there. So I just go with a 24 gauge, a 22 gauge, blue one.
But you can use a yellow one as well. But a blue one, I mean, if you're going to cannulate it.
Yes, you can use a yellow one. The guide wires do go through them, but I don't even bother. I don't have a good reason though, and I can't say that the one is better than the other. Okay,
that's great. Any more questions? Otherwise, we would really encourage you again to go and check out the website. And then we will see you again in April, the last Thursday, and we're going to do a research discussion then, and there will be some great presenters again. So thank you so much for all our presenters, for Alan and for Kotie and for Beira all the way from Australia, and we've learned really a lot from you today, so we really appreciate it. Okay, and enjoy the rest of your week.